Up Chapter 10 and the upper extremity, we're going to now turn our focus to the wrist, hand, and fingers. Although the wrist, hand, and fingers are small body areas, they can still become injured during activity. The hands and fingers provide grip and dexterity. Full function of each joint is truly important for different activities. Many wrist, hand, and finger injuries are not medical emergencies. However, we need to make sure that we provide the proper treatment for each situation. Again, we will look at fractures to begin with. Fractures can occur to any of the wrist, hand, and finger bones. However, the most common fractures are to the distal end of the radius. This is called a Colles fracture, the fifth metacarpal, or Boxer's fracture, the base of the first metacarpal, which is called a Bennett's fracture, and other metacarpals such as the third metacarpal, the scaphoid, the hamate, and the phalanges. When we look at mechanisms or causes of injury, typically these body parts are injured by a direct traumatic force. Specifically, a Colles fracture typically occurs when an athlete falls on an outstretched arm. A boxer's fracture can occur when an athlete strikes a hard, immovable surface with a closed fist. A Bennett's fracture occurs when an object strikes or an athlete falls on the tip of the thumb when in slight flexion. A scaphoid fracture, which is in the snuff box of the hand, can occur by falling on an outstretched arm. The scaphoid fracture can also occur as stress fractures, with repetitive lower intensity forces over time with the wrist in extension. This can put undue stress on the scaphoid and eventually lead the bone to break down. Due to the location of the hamate, it can be fractured most often when the athlete is holding an implement, such as a hockey stick or a tennis racket. Any metacarpal or phalange can be fractured by getting hit on the tip of the finger or when an athlete is stepped on during play or practice. Typical signs and symptoms of fractures in the wrist, hand, and fingers include pain, point tenderness, loss of function, and muscular stiffness. Swelling may also be present with some discoloration. The area may or may not present with deformity. As you can see in the picture there, that is an x-ray of a fracture, a spiral fracture of the fourth phalange. And we can see that there is some deformity, that it is off to the side there. For immediate care, we want to treat it and begin with rice and splint the area. If traumatic, we need to call 911 if the athlete is experiencing severe signs and symptoms of the injury, has an open fracture, has a loss of feeling or function, or is going into shock. For prevention, we want to make sure that they're performing activities correctly, such as catching the ball correctly, landing correctly. Athletes should also wear proper protective gear for the area, and then again have a correct amount of vitamin D and calcium in their diet. Dislocations can also occur at the fingers. Lunate and phalangeal dislocations are very common in these areas. And lunate dislocations are often assumed to be a wrist sprain until it is x-rayed. Finger dislocations, as you can see in that picture, are very noticeable that you can't really make that up and see that it is something else. When we look at mechanisms of injury, it's caused by when a direct traumatic force strikes the palm of the hand at the lunate, such as when a person falls on an outstretched arm. Phalangeal dislocations occur when a person that may be stepped on by another athlete, or they have a blow on the tip of the finger from a ball or an implement when they're trying to catch it. Signs and symptoms are the same as other suspected dislocations: pain, loss of function, significant deformity, especially for phalangeal dislocations, as well as swelling and ecchymosis. Immediate treatment, we want to make sure we splint the area, apply ice, and summon EMS. We definitely, like the shoulder, like the elbow, we don't want to reduce any of these dislocations unless we are trained to do so, because if we reduce it and we're not trained to do so, we could be causing further injury to the injured body part. So we need to make sure that we refer them by summoning EMS or sending them to the emergency room to get it treated. Also, we need to be aware of treating for shock if it does occur. For prevention, make sure we need to teach the individual how to fall, try to avoid falling on an outstretched arm or hand, and be cognizant of their surroundings and their skills of catching a ball. Sprains of the wrist also occur, and they can occur at any of the joints of the fingers. Collateral ligaments exist not only at the elbow but also of the wrist and fingers. The wrist joint and every joint of the finger, including the distal, proximal, and metacarpal phalangeal joints, have medial collateral ligaments and lateral collateral ligaments. So any one of these different ligaments can be sprained. Again, like the elbow, the medial collateral and lateral collateral sprains occur due to varus and valgus types of forces. When we look at mechanisms, we know that an athlete can fall an outstretched arm. The phalangeals, or fall an outstretched arm for a wrist sprain. For phalangeal joints, they can be sprained by a blow on the tip of the finger, or similarly to the elbow, valgus forces applied to the wrist and phalangeal joints can result in an MCL, whereas an LCL can be sprained by a varus force. Signs and symptoms are very similar to what we talked about before: pain, swelling, stiffness, signs of inflammation in that area. For treatment, we want to apply the Rice principle. We can also take over-the-counter NSAIDs to reduce pain and inflammation. Once the signs and symptoms have subsided, the athlete can slowly progress to perform active range of motion strengthening activities. If it is a grade 3 sprain, we may want to refer them to a physician just to have them looked at to make sure that there's no fracture in the area. To prevent a sprain type of injury, an athlete should avoid falling on an outstretched arm with the wrist in extension. We should also take precaution to prevent valgus or varus forces to the wrist and fingers to minimize trauma to the MCL and LCL in that area. A very common injury that we are typically well versed in or well aware of is carpal tunnel syndrome. The carpal tunnel is an area of the anterior wrist that contains the median nerve and the wrist and finger flexor tendons. The carpal tunnel syndrome is a chronic condition that involves the median nerve where it occurs in the lay population, typically of an older age, between 30 and 60 years of age, and typically occurs more in women than in men. When we look at mechanisms, carpal tunnel syndrome can occur to anyone who uses the hand in repetitive motion, such as typing, racquetball, handball, and other activities that require the athlete to grip an implement or perform wrist flexion. Are really the most prone to this type of syndrome. Others who participate in long periods of computer use, writing, sewing, and other kind of fine motor skills are also susceptible to carpal tunnel syndrome. Signs and symptoms include tingling and numbness, pain, weak grip strength, and decreased function and coordination of the area. And all this occurs because that median nerve is inflamed, causing pressure on that nerve, making that tingling and numbness sensation down to the fingers from the wrist. Treatment, we want to refer to a physician. When we look at treatment, we want to make sure it is carpal tunnel syndrome. We can check that before referring to a physician by looking at Tinel sign. Tinel sign is when we take the athlete's wrist facing up and we gently tap over the wrist area where the median nerve is located. If the athlete feels tingling to the wrist and fingers, this is a positive test for carpal tunnel syndrome. So if we find that test to be positive, we should refer them to a physician. We can also use rice or moist heat to eliminate any pain or inflammation. Try to discontinue the activity that causes the symptoms to worsen, as well as take over-the-counter anti-inflammatory medications, possibly splint the wrist at night or during the day in an extended position. For prevention of carpal tunnel syndrome, we want to refrain from keeping the wrist in flexion for long periods of time. And if we cannot do that, wear preventative ergonomic equipment to keep it in some sort of a comfortable, less stressed position and in some sort of slight extension. De Quervain's tenosynovitis is also a type of overuse chronic type of injury where it's a condition in which the synovial sheath of the tendons that abduct and extend the thumb become inflamed, very similar to carpal tunnel syndrome, but on the thumb in this situation. When the sheath of the tendons becomes inflamed, the tendons cannot move properly inside the sheath. When we look at mechanisms, it's caused by repetitive movements. When the thumb is constantly gripping or in a fist, such as when they're holding a racket or a dumbbell, we can irritate the thumb tendons, or other situations where we complete a repetitive wringing motion, such as wringing a towel, can also cause inflammation. Signs and symptoms include pain at the base of the thumb, especially when gripping objects or making a fist. Swelling, crepitus, and loss of function can also be apparent in this injury. Treatment, we want to apply ice or heat to decrease some of the inflammatory signs and symptoms. Then we can refer to a physician. Before we refer to a physician, there is a test, kind of like carpal tunnel syndrome. In this situation, it's called Finkelstein's test. And we have the athlete make a fist with their thumb inside and then passively move the wrist immediately to apply a stretch to the thumb tendons. If there is pain in this movement, it can indicate de Quervain's tenosynovitis, but if you just take a second and do that motion now, make a fist with your thumb inside, and then passively flex that wrist, you may have some slight tenderness. So it's not the best test, but we can use it to see how much pain they actually have in this motion. If they do have pain, we can again refer them to a physician who will probably prescribe the athlete some sort of NSAIDs and rehabilitation, and possibly wear a splint in the area to keep the thumb in a rested and straightened position. For prevention, we want to avoid gripping and wringing activities and perform thumb active range of motion as much as possible. Next, we have gamekeeper's thumb. When we look at gamekeeper's thumb, another repetitive type of chronic injury. This is a sprain and a resultant of chronic ulnar collateral ligament laxity of the thumb's metacarpophalangeal joint. There is an acute variation of this, and it's called skier's thumb. But when we look at gamekeeper's thumb, the biggest mechanism for gamekeeper's thumb is repetitive valgus force to the thumb when it is in extension and abduction. This repetitive force is placed on the thumb as it is in a position furthest away from that second finger or pointer finger. So this creates an L appearance with the second finger, especially when a skier falls or when somebody falls on a pole and their thumb is pushed with a valgus force causing the injury. Signs and symptoms, we have pain, deficient grip strength. Pain most often occurs when the athlete makes a pinching motion with the thumb and index fingers, and we can also have swelling, ecchymosis, and joint laxity in the area. Treatment, again, we're going to use the Rice principle. We can splint the thumb in a comfortable position and take NSAIDs for inflammation and pain. If the athlete has an increase in symptoms or significant joint laxity, we should refer to a physician to make sure that there's nothing else going on in the area. For prevention, we need to be careful when falling on an outstretched arm and when blocking an opponent with the hands. Just think about football linemen when they go up to block. Their fingers are outstretched, almost in that L position anyways, and then they're having another individual push on them, which could cause that overuse, ulnar collateral ligament laxity, or injury in that area. Lastly, we're going to finish up on some deformities of the finger. The first two we're going to look at are mallet finger and boutonniere deformity. And when we look at these two, mallet finger is a rupture of the finger's extensor tendon at the distal interphalangeal joint, or the DIP joint. Compared to the boutonniere deformity is a rupture of the finger's extensor digitorum tendon at the proximal interphalangeal joint. You can see that they're both extensor type of tendon injuries. One, however, is at the DIP, and that is the mallet. The other one is at the PIP, and that is the boutonniere deformity. Within these two deformities, we can also have an avulsion or other fractures that can occur if this occurs acutely. For mechanisms, these deformities occur when we have a force at the tip of the finger that forcefully flexes the finger at the joint, either the DIP or the PIP, such as when we catch a ball or getting hit the tip of the finger with a ball. Signs and symptoms include finger deformity, swelling, redness, ecchymosis, and point tenderness. Treatment for these two deformities, we can apply a splint in which the injured joint is splinted in extension so that the tendon can rest and have decreased pain, as well as apply ice and refer to a physician to make sure there's no avulsion or other type of fracture in the area. For prevention, we need to be careful when catching equipment and use proper catching skills to make sure that we don't have these occur to the joints of the finger. Lastly, we're going to look at jersey finger. Jersey finger is very similar to mallet finger because the finger distal interphalangeal tendon is torn or ruptured. However, the ruptured tendon is the flexor digitorum profundus, which is another flexor tendon in the area, which commonly occurs at the fourth finger DIP area. The tears of this can be partial or full ruptures, and we typically see these ruptures occur when an individual grabs an opponent's jersey. And this is where it got its name, jersey finger, because it's caused by the athlete forcefully contracting the finger's flexor tendon around a jersey, and the person's jersey being forcefully pulled away, causing a rupture in that tendon. Signs and symptoms we see with a jersey finger include pain, loss of finger flexion. The athlete may have heard a pop or felt a snap at the time of the injury. The athlete cannot flex the finger at the DIP joints. It could be point tender. There could be numbness, tingling at the tip of the finger, as well as swelling, redness, and ecchymosis. Typical treatment for a jersey finger, we want to make sure that the tendon is intact as much as possible. Because this is a more significant type of injury, we want to make sure we treat for shock if that occurs, call 911 if necessary, and that our typical Rice principle, apply ice and splint the injured joint in a slight flex position so that we can relax that tendon. For prevention, again, we want to make sure that we perform and practice proper catching skills to avoid this type of injury. Now, as you'll see, I did skip a couple of injuries. Please review Desputain's contracture, which is at the end of the chapter, as well as a ganglion cyst. Just look at those real quick throughout this last section of the chapter, because again, it could be on the quiz for learning module 3.